Good morning. This is Jess. I am continuing on with the video series that I started the other day, so hence the outfit change. And let's talk about the nursing process for people with male reproductive organs that isn't related to cancer. So I'm going to share my screen. And there. Okay. So when we're talking about the nursing process, we're of course talking about ADPI. So the assessment for these people are some different things that we need to take into consideration. So we're going to be talking to them about subjective stuff, how they're feeling, what sort of stuff they're reporting, what sort of signs and symptoms they're noticing, and then we'll also talk with them about, are you on testosterone supplements, perhaps for low T, perhaps for other reasons, including outside of doctor's care. We can also take a look at whether they've had previous treatments for BPH or any sorts of things of that nature, functional health patterns. We're going to be doing a lot of assessing about their knowledge of the condition. Are they doing some sort of voluntary fluid restriction where they've opted out of because they are having so many urine problems, or problems with urination, they're actually opting out of drinking fluids and causing dehydration. How is their elimination? Do they have urgency? How is the force of their stream? Is there a pause when they get to, when they finally get into the bathroom and they get all set up? Is there a hesitancy in initiating voiding? Not a hesitancy like, oh, I don't know if I should be voiding, but come on, let's void. Okay. All right, and then it goes. Is there any post-void dribbling? Is there any urinary retention, like they feel that their bladder is not empty after they've gone and voided? Is there any urinary incontinence? All of these are reasons why people will sometimes do a voluntary fluid restriction. How is their rest? People with BPH have problems sleeping. They will get up probably 4 or 5 times a night because of incomplete bladder emptying, and they will be up all night and not getting good sleep. How is their cognitive perception of things? Is it painful? Can they sense if they are having incomplete voiding? Do they have bladder discomfort? And are there any anxieties that they're having about sexual dysfunction? When it comes to objective findings, in general, older adult males are going to be more susceptible to this particular problem of BPH. Urinary, we may feel a distended bladder upon palpation. And in that digital rectal examination, there may be a smooth, firm, elastic enlargement of the prostate. Possible diagnostic findings include an enlargement on ultrasound. If they do a cystoscopy, where they actually take a camera and examine the urethra and the bladder, there may be an obstruction. There may be residual urine. We may be doing urinalysis findings. There may be increased creatinine levels. And we may have that elevated PSA as well in this particular case. Diagnoses include acute pain, impaired urinary system function, temporarily impaired sexual function, and risk for infection. The risk for infection comes from this impaired urinary system function. So when we get into implementation, there's a few different things that we can be doing for people. We can be doing PSA screening tests. That prostate-specific antigen is something that guidelines are changing on, but go with the current guidelines that are in SurePath in your book for testing purposes. But that PSA screening is done on a fairly regular basis for health promotion. Avoiding alcohol and caffeine because they have diuretic actions. And then Sudafed and phenylephrine have smooth muscle contractions. We want those muscles to be able to relax as much as possible when it comes to the urinary sphincters and the urethral sphincters. So if we can avoid meds that have smooth muscle contraction, that's a bonus. If there is some sort of obstruction from the prostate squeezing that urethra too much, we're going to be encouraging them to urinate for every 2 to 3 hours, just to be able to keep the bladder out as empty as possible. And please encourage these people to not limit their intake for hydration. An accidental dehydration, it really is, because they're withholding fluids because they're having urinary problems, is a much bigger problem to fix. This person is having a surgical intervention. We're going to be doing preoperative care, including treating and managing any UTIs that they have. We're going to be restoring urinary drainage, including perhaps adding a catheter to their urinary system, and then making space and time for concerns about sexual function. I know that I've mentioned sexual function a couple different times in this particular part of the slideshow, and you have to understand that sexual function is huge for people regardless of age. So having a safe space to talk about sexual function is wildly important to your client. For post-operative care, we'll be monitor for complications like hemorrhages, bladder spasms, urinary incontinence, infection, and maintaining CBI. That's continuous bladder irrigation. I got a slide about that. It's coming up next. So I'll put a pin in that and we'll get to that the next time, or in the next slide. And then ambulatory care after discharge from the hospital. We're going to be teaching people how to care for their indwelling catheter. These people will probably go home with an indwelling catheter if they've had a prostatic surgery. How to maintain urinary incontinence, managing adequate oral intake, bladder capacity. All of this bladder, post-surgical bladder stuff can take up to 2 months to be able to resolve. So they're in this for a little bit of the long haul. As far as the surgical site, we're going to be teaching them how to observe for UTIs and infections, preventing constipation. That's wildly huge. So we're going to be putting them on some stool softeners, some fiber supplements. Partly because they're going to be on pain meds, and partly because they're not going to want to push because it creates extra pressure on their urinary system. So what we'll do is we'll be talking to them about stool softeners and bowel regimen or bowel management so that they can prevent constipation. They should be avoiding heavy lifting. They should be refraining from driving. They should be refraining from intercourse. And remember earlier today I was saying, or earlier in this slide, I was saying that sexual function is wildly important, regardless of age. Erectile dysfunction can take up to 2 years to resolve. So just be aware of that. That's a big hit to someone's ego, is you're not going to be sexually functioning for 2 years because of the surgery that we're doing to save your life through your bladder and your kidneys. So there is a definite trade-off, and it could be a very difficult situation for a person to navigate. So being aware of that is very important. Remember when I said I was going to put a pin in CBI? Here's CBI. So CBI stands for continuous bladder irrigation. There are very similar post-op and post-op considerations that are associated with any sorts of surgery, right? However, we're going to add a layer onto this. So the layer that we're adding here is a 3-way catheter rather than a simple catheter, one single tube that goes all the way down to the drainage bag. In this particular situation, there is their catheter has what you can see here is there is 3 different ports. And so this bag is called the irrigation bag, and this is a drainage bag. And so what will happen is we'll put this at gravity level and we will titrate the flow from the irrigation bag based on the color of the drainage in the drainage tubing. So you'll have orders. This is an interesting situation. So you'll have orders that will say titrate irrigation fluid to be light cherry colored, rather than titrate for X amount of drops per hour or X amount of it's not a very specific given thing. The whole reason why this is occurring is to be able to prevent large clots from interrupting the urine flow from that bladder, because we just did surgery in their urethra. So we need to be able to make sure that all of that surgery doesn't get stopped up. So this is how we're going to do this. What happens for the charting end, like how do we chart I's and O's when we're titrating fluids to being a color? Here's how we do it. So the output is tracked hourly. And then what we're doing is we'll actually take a look at how much is out in the drainage bag, and we will subtract how much irrigation has come out of the irrigation bag, and that's our output. So your urine output is tracked hourly, and you have to know how much irrigation's gone in, and then you subtract that amount from the total that's in the drainage bag. You go through a lot of irrigation bags. These irrigation bags are like 2 or 3 liters big. They're huge. And this drainage bag is also huge. It can hold like 4 or 5 liters. But there is a lot of changeover when it comes to these sorts of things. But it is a continuous bladder irrigation to be able to keep the clots. That's why there's these little bits and pieces that you see in here. These little bits and pieces are clots. If you have this clot off, it is wildly painful because the irrigation bag hasn't stopped yet. And all you're doing is you're having this bladder grow and grow and grow and grow with all this irrigation, and it causes a wild amount of pain. So you will be working with experienced nurses the first few times that you're doing continuous bladder irrigation. If you've never done it, like let's say you've been on the floor for, I don't know, in Jess's case, it's like a year and a half. She'd never done bladder irrigation, and she got a post-op person that needed to have CBI. So I leaned heavily on my charge nurse buddies from MedSurg to give me some coaching and advice. And the MedSurg nurses that had transferred from MedSurg to my unit, I leaned on them as well. And it was definitely a teamwork makes the dream work. Give Jess some crash course education about CBI to be able to have this be successful. I did have it clot off. We did work to get it unclotted or unclogged or unclotted, declotted. Anyway, and the guy was in so much pain, and then he was so thankful afterwards. He brought us the good cookies with the bakery sugar cookies with that really crispy icing. Not like the buttercream, like swirly ice cream that they put the sprinkles in, but like the crispy icing. Anyway. Evaluation after BPH surgery, expected outcomes is this person should be able to report that they have acceptable pain, and they should be reporting improved urinary function with no pain or incontinence. I'm going to stop sharing here. Come on, stop sharing. And I will see you back here for male reproductive organ cancers.